You think a pharmacy makes money selling medicine. You walk up to the counter. You hand over your insurance card. A pharmacist counts 30 pills into an orange bottle, hands it over, and the register shows a copay of $10. Simple transaction, right? A product changes hands. A business gets paid. Everybody moves on with their day. Here's the number. That should stop you cold. Independent pharmacies across the country are now losing money on more than 60% of the prescriptions they fill for Medicare patients. Read that again. On the majority of prescriptions walking out the door, the pharmacy is paying more for the drug than it's being reimbursed to dispense it. Every single fill is a loss, subsidized by whatever's left in the register from something else. That's not a struggling business model. That's a business getting paid less than what it costs to operate, on purpose, by design, for most of what it sells. So who's actually setting that price? Why have over 300 pharmacies closed in the United States since just the end of 2024? And why does the company processing your insurance card, the one deciding how much your neighborhood pharmacist gets paid, often turn out to be the exact same company that owns the pharmacy down the street? Let's take it apart. Picture the counter, the white coat, the little printer spitting out a label. Everything about that scene says healthcare, provider running a business. Here's the number that breaks that image immediately. Nearly 29% of all U.S. pharmacies closed between 2010 and 2021, not because people stopped needing medication, prescription. Volume climbed the entire time. They closed while demand for their product was rising. A business selling something people need more of every single year, closing at scale, isn't a story about bad management. It's a story about something structural sitting underneath the counter that most patients never see. Meet Dave Miller, who's owned Keystone Compounding Pharmacy for 25 years. He didn't say business got harder because of bad location, bad staff, or bad service. He said the reimbursement system itself has been a headache for the last 30 years. And in 2026, that headache has become an existential threat, not a minor annoyance. Here's the assumption almost everyone walks in with. The pharmacy sets the price. Insurance covers most of it, and whatever's left over is the pharmacy's cut. Standard retail, just with a middleman called insurance, destroy that assumption in one sentence. The pharmacy doesn't set the price at all. A separate company decides, unilaterally, exactly how much that pharmacy gets paid for every single prescription. And the pharmacy finds out the number only after the medication has already left the building. That separate company is called a Pharmacy Benefit Manager, a PBM, and here's the part that should genuinely unsettle you. The pharmacist has almost no leverage to negotiate. It's a take-it-or-leave-it contract. Reject the terms, and the pharmacy loses access to every patient covered by that plan overnight. Picture what that actually looks like on January 1st, when annual contracts reset. A pharmacy owner opens an email with new terms attached, terms they didn't negotiate, can't meaningfully counter, and must accept or lose roughly a quarter of their entire patient base in a single day. That's not a business relationship. That's a mandate delivered by a company the pharmacy has almost no power to push back against. The next theory. Fine. PBMs negotiate hard, but that's just their job. Squeezing costs down benefits patients and employers footing the insurance bill. Aggressive negotiation on your behalf. That's the pitch. Here's where that story falls apart. Just 3 PBMs process roughly 80% of all prescription claims in the entire United States. That's not a competitive marketplace disciplining prices downward. That's 3 gatekeepers controlling the pipeline nearly every pharmacy in America has to pass through to get paid at all. And each of those 3 gatekeepers isn't actually a neutral referee. CVS Health owns CVS Caremark, the PBM, and also owns CVS Pharmacy, the retail chain, and Aetna, the insurer. Cigna owns Express Scripts, the PBM, and also owns Accredo, a specialty pharmacy. United Health owns Optum Rx, the PBM, and also owns its own specialty pharmacy network, and the insurance company writing the coverage in the first place. The company deciding how much your neighborhood pharmacy gets paid is frequently the parent company of a competing pharmacy down the street. Ask yourself the obvious question. If you controlled the price your competitor got paid, would you set it generously? Independent pharmacy trade groups have been saying this out loud for years, but 2026 is the year the math finally became undeniable. Reform advocates estimate independents are now losing money on roughly 20% of all the prescriptions they fill across every payer type. Not just Medicare, a floor beneath which an entire category of small business is being asked to operate. Here's the mechanism. Laid bare. When a PBM is owned by the same corporation as a retail pharmacy chain and an insurer, that structure hands the parent company an incentive nobody outside the industry expects. Advocacy researchers have documented it plainly. PBMs merged with retail pharmacies have a greater incentive to pay independent, competing pharmacies less, while steering patients quietly toward the pharmacy owned by the same parent company. Picture the mechanics. A PBM sets the reimbursement rate for a common generic blood pressure medication below what it actually costs a small pharmacy to acquire the pills wholesale. That independent pharmacy loses a few dollars on every single fill. Multiply that by the volume of prescriptions a single pharmacy processes in a year, and the losses compound into the very closures driving today's headlines. Now follow where that same dollar goes inside a vertically integrated giant. The PBM arm pays itself, the affiliated retail pharmacy arm, for the exact same prescription, often at a rate structured to protect the parent company's total profit. The insurer arm, meanwhile, collects premiums, calculated against a drug price the PBM arm has already inflated through a practice called spread pricing, charging the health plan more for a drug than what's actually paid out to the pharmacy that dispensed it, and quietly pocketing the difference. 3 business units, 1 parent company, 1 drug, 3 separate profit opportunities extracted from a single prescription. While the independent pharmacy across town, with none of those 3 arms, absorbs the loss on the exact same pill. Some of these companies say they're changing course. CVS, for instance, rolled out a new cost-plus pricing model in 2025, explicitly moving away from opaque spread pricing toward a transparent formula. Drug cost, plus a set markup, plus a dispensing fee. Positioned as a transparency win, and it may well reduce one specific practice, but it does nothing to address the deeper structure underneath it. The same company still owns the PBM setting the rate, the pharmacy filling the prescription, and the insurer collecting the premium. Transparency about the math doesn't change who's still holding all 3 seats at the table. Why doesn't the average patient notice any of this? Because the entire system is engineered to make the transaction feel simple. You hand over a card. A number appears. You pay it. The complexity, the PBM contract, the spread pricing, the below-cost reimbursement, happens entirely behind a curtain you never see. Processed in milliseconds between the moment your prescription is scanned and the moment your copay appears on screen. Trust plays a role too. A white coat, a familiar pharmacist who's filled your family's prescriptions for years. That relationship reads as neutral, professional, disconnected from corporate incentives. Patients rarely stop to ask whether the person recommending a specific pharmacy, or the plan quietly steering them toward a mail-order option, is doing so purely on clinical grounds or because a parent company profits more when the prescription is filled somewhere else within the same corporate family. And here's the twist that should genuinely bother you. Some PBM contracts have historically limited what a pharmacist is even allowed to say to a patient about cheaper alternatives. A gag clause, effectively silencing the one person in the transaction whose entire professional training is about helping you make an informed choice. The system isn't confusing by accident. Confusion, at this scale, is load-bearing. Every industry running this kind of extraction eventually meets its own reckoning. Here's this one's unfolding in real time. State legislatures are moving fast in 2026. Louisiana now requires PBMs to reimburse pharmacies at least the actual cost of a drug. Mississippi's House passed similar reform by a lopsided vote. Oklahoma lets pharmacies refuse to dispense when reimbursement falls below acquisition cost. Iowa banned below-cost reimbursement and spread pricing outright. Federal reform arrived too. The Consolidated Appropriations Act of 2026 separated PBM compensation from drug prices and rebates, specifically in Medicare Part D, aiming to remove the incentive to favor higher-cost medications. But here's the uncomfortable twist. Industry advisors are already warning that PBMs are adapting faster than regulators can legislate, replacing simple upfront fees with performance-based reimbursement models that are harder to audit, harder to predict, and just as damaging to a pharmacy's cash flow. Just quieter about it. There's a second threat compounding the first, the workforce itself. Only around 8,000 new PharmD graduates are expected in a recent year, roughly 60% of what the industry actually needs to keep pace. A business model already squeezing pharmacies on reimbursement is now colliding with a shrinking supply of pharmacists willing to work inside it. The bomb here isn't hidden in a boardroom. It's sitting in plain sight in state legislative sessions, in graduating class sizes, and in a below-cost reimbursement rate that keeps compounding. Contract renewal after contract renewal. There's a quieter version of this fight too, one that already happened once and lost. A few years ago, regulators cracked down on something called DIR fees. Retroactive clawbacks, PBMs, would apply to a pharmacy's payment months after a prescription had already been filled, making it nearly impossible for an owner to know their real margin until long after the sale. That specific practice got reformed, but industry veterans describe the exact same pain reappearing under a new name: performance-based reimbursement, proving that closing one loophole doesn't close the underlying, incentive-driving PBMs to find the next one. So where does this split? On one side, continued consolidation at the top. The three vertically integrated giants keep capturing a larger share of the market's most profitable segment, specialty pharmacy, where they already control roughly 2/3 of all dispensing revenue, worth close to $200 billion. That's where the real margin lives now. Complex, high-cost specialty drugs, not the everyday generic prescriptions squeezing independents to death. On the other side, independents that survive are the ones actively building revenue the PBM contract can't touch. Long-term care partnerships serving aging patients outside facilities. Niche compounding, hormone therapy, specialized formulations. Cash pay categories like veterinary medication, where no PBM sits between the pharmacy and the customer at all. The pharmacies making it through 2026 aren't waiting for legislative reform to save their margins. They're rebuilding their revenue model around whatever a PBM contract can't dictate. The middle, the traditional, prescription-only neighborhood pharmacy with no specialty niche and no PBM leverage, is exactly where the closures keep concentrating, and exactly where rural America is starting to lose access to medication altogether. One more piece is quietly reshaping who survives. The 340B program, which lets certain hospitals and clinics buy drugs at a steep discount and dispense them through contracted pharmacies. Net sales under that program have been expanding at double-digit rates, now exceeding the size of the traditional rebate-driven part of the market it was originally meant to supplement. For a pharmacy able to plug into a 340B contract, that growth is a lifeline. For one that can't, it's one more advantage flowing to whoever already has the scale and relationships to access it. Picture two pharmacies opening on opposite ends of the same metro area. Path 1. The independent, prescription-dependent pharmacy. No PBM affiliation, no specialty niche, no leverage in contract negotiations. Losing money on the majority of Part D prescriptions it fills, subsidizing those losses with whatever margin survives on front-end retail and the occasional cash pay customer. Exposed directly to every reimbursement cut a PBM decides to impose, with no recourse beyond a take-it-or-leave-it contract. Path 2. The vertically integrated chain pharmacy. Owned by the same parent company as the PBM setting reimbursement rates system-wide. Every prescription filled here generates value at multiple points in the same corporate structure. The dispensing margin, the specialty pharmacy premium, the insurance premium calculated against an inflated list price. The losses independents absorb on generic drugs are, for this pharmacy, largely irrelevant, because the real profit was captured somewhere else in the same building's org chart. Same white coat. Same orange bottle. Same insurance card swiped at the register. One pharmacy is structurally guaranteed to lose money on most of what it fills. The other was built, deliberately, to never have that problem in the first place. So go back to that counter, that white coat, that $10 copay. It was never really a simple retail transaction. It's the visible tip of a 3-layer corporate structure most patients never see. An insurer, a pharmacy benefit manager, and a retail pharmacy, frequently owned by the very same company, extracting value from the same prescription at 3 separate points before you ever see the total. The pharmacies losing money on 60% of what they fill aren't failing at business. They're the ones standing outside that structure, absorbing costs the system was never designed to let them recover. The medicine was never the product being priced. The gatekeeping was. Next time you hand over your insurance card and watch a number appear on the screen, remember what actually just happened behind that curtain. Somewhere, a company you've never directly paid a cent to just decided exactly how much your neighborhood pharmacist earned for keeping you alive, and there's a real chance that same company also owns the pharmacy standing right next to the one you walked into. The white coat never changed. The counter never changed. What changed, quietly, over the last 2 decades, was who actually gets to decide whether the person behind that counter can afford to keep the lights on tomorrow.